Hello, everyone, and welcome to another deep dive session with PEGA, Practical EKG Academy. Today, we're going to be taking a look at this 12-lead ECG, right? We're going to be breaking it down. Actually, we're just going to start off with a single lead and jump right into the 12-lead. Kind of missed the in-between step with a couple of different channels, but that's not going to take away from the lesson. Okay, so, yeah. As always, I want to remind you, work on your method, any method. Doesn't matter if it's a single step or 300 steps, but have something to help you out when you're tired, when you're confused. You know, it's really going to get you back on track. Okie dokie. So somebody hands you this strip, right? Now, if you watch the rapid ECG video, you already know what this is. Here we're going to be going into a lot more detail, I would say. You know, I'm not going to be revealing anything profound here or new, but we will be going into a little bit more detail, actually a lot more detail. But okay, so 10-second strip, channel 2, right? Most commonly used lead. The best you can hope for with a single channel is rate and rhythm, right? Anybody says rate, you immediately say rate of what? And as far as the rhythm goes, maybe you get lucky and figure out what it is on a single channel. Maybe. Okie dokie. So, first thing that really stands out is we have, you know, a very slow ventricular response with, you know, basically gaps with these little bumps on there, which I'm assuming are P waves. So I'm just going to start throwing arrows up on them wherever I see them. So there's a bunch of these, right? And there seems to be 2 of these bumps. And then we get a QRS. Okay. Now, as far as the QRS goes, right, that's the QRS. These are the blue arrows. I was nice enough to throw a couple of different colors at you instead of magenta. You're probably getting sick and tired of magenta. All right, so let's get to it. Now, I'm not sure what I'm looking at here. I mean, I already know what this ECG is right before I started making the video, but realistically, if somebody threw this strip at me, I would have to answer a couple of questions to be 100%, to be definitive about my analysis, my interpretation. And here, I'm going to do that step by step. So first of all, I want to figure out some rates here. Because immediately, this to me looks like a block, right? We're getting a P, and then we're getting a P, and it's not super fast. It's not irregular. It seems pretty steady. But what the hell is this? You know, why is there a gap here? Whereas I should get more of them. It seems like there's a profound distance from this one to this one versus from this one to this one. So I'm just going to grab some rates here. And here, what do we have? You know, I just did the rapid video, and I can't remember the rates on this. But so from here, this starts on the second box, and then we go 300, 150, 100. 100 and 1 box less. So this is maybe, oh yeah, 98. I think it was 98. Maybe it's 97. Doesn't matter. It's a little bit less than 100. So that's for the supposed atrial rate, right? So from here to here, we're getting 98 beats per minute. And then here, I have no idea. And then again over here, we get 300, 150, 100, a little bit less, so the rate is the same. So interesting, the rate here and here is the same. So now I'm definitely suspecting, you know, second-degree block or block of some sort, maybe even a complete heart block. But let's keep going. While I'm down here, I want to take a look at the rate here. And I want to measure the rate from this QRS to this QRS. So I'm just going to use the peaks. I mean, we can go down here, but the rate is so low that one small box won't really make a difference. So 300, 150, 100, 75, 60, 50, 43, 37. I forget the next one. I think is like 35 or 33. But I want to show you here. I'm going to measure the boxes. So each box has each big box has 5 small boxes, right? So 5, 10, 15, 20, 25, 30, 35, 40, 45, and then we have 46, 47, 47 and a half. So you can use the 1500 method and divide this by 47.5. My goodness. Or you can use this ruler, right? And the way you would use it is this way. So this is the 300 method, the very first line up here. And then we have the 1500 rule on the next line. And that's measuring the small boxes. So I hope that's making sense. So up here, this 300 is pertaining to this line, 150 to this line, 100 to this line, right? But in between the small lines, right, this is 1500, 750, 300, blah, 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 so on and so forth. Now we had 47 and a half small boxes. So, whoops, I didn't mean to zoom out that much. You can count these out, right? 1, 2, 3, 4, 5, or 5, 10, or down here, these numbers, right? 5, 10, 15. I'm looking for 47 and a half. So right here, 45, 46, 47 and a half. This is where my R to R rate was. And up here it says 32 for the 47. So the rate was 32, and this little arrow pointing up, it means that the number was rounded up. Okay, so the number at this point was probably a little bit less, like 31.8 or something like that. But my rate is between 31 and 32 beats per minute. Not that it matters, I'm just showing you how to use this ruler. Okay, so if you went to Pega.com and downloaded this, this is how you would use it. If you took a screenshot of this and printed it out, this is how you would use it. It's basically a mnemonic, right? Okay, so going back to the ECG. Now I know my rate here is between 31 and 32 beats per minute. So I'm just going to say 31.5, not that it matters. That is very low. You would expect this to be a junctional rate, right? But is it? Let's keep going. Okay, so we have an atrial rate, 98 beats per minute. We have supposedly we have an atrial rate, 98 beats per minute. And then we have this 31 and a half happening over here. So let's keep going. Let's keep going. What else can I grab off of here? Not much, really. These are about the same. Now this is interesting, and this I'm going to have to take a closer look at. So right now I'm suspecting that this is a block, and I'm suspecting that there should be a P wave buried in this T wave. There has to be, in order for this to be a block, a straightforward block without something really, really extraordinary going on. So let's take a look at the 12 lead. Again, this is a single channel, right? You get this, if you have experience, you've already figured out what this is. But if not, then things get a little trickier. So moving on to the 12 lead. Now I jumped a step where we show only a couple of leads, but that in between step typically has V1, lead 2, and V5. Here, immediately, do you see that? Look at that. Boom. In V1, we see 3 bumps to every single QRS, right? Sorry, let me just copy this. So what I was talking about, that P wave being hidden in the T wave, now came true. But I needed lead V1 to confirm that. I'm really going to drive this point home. So this right here is atrial, right? I'm just going to draw a line. And this is something you should do when you're, you're out in the field or you're in the hospital or whatever the case is. Take a straight edge, any straight edge, as long as you're sure it's straight. Find whatever it is that you're looking for, draw a line, and see where it lands in other leads. And all of a sudden, I see that this little peak, I'm just going to move the line over so you can see, this little peak corresponds to the peak of the P wave. Now, this is a pretty straightforward one, but this comes in handy when you're looking at very, very difficult stuff. Okay, now another thing I want to take a look at. This right here, to me, looks very much like an incomplete right bundle branch block because of this slurred S over here. So this, in lead V1, when I see this, my mind immediately goes to right bundle. Okay, so I want to take a look at the width of this QRS, and it really starts right here on this line. We move over one box, that's 40 milliseconds, 80 milliseconds, and it would end right about there. So this QRS is 120 milliseconds wide or long. Now we're getting into some funky stuff. Why? Because 120 milliseconds, when you start talking to anybody, right, they say 120 milliseconds, oh, you have intraventricular conduction delay, or you might have a bundle branch block. And that very well might be the case here. Not that it's necessarily relevant when you have a block that's a far more serious issue than a bundle branch block, but nonetheless, it is significant diagnostically. So let's keep going. So far, what do we have? We have 3 P waves, 2 AQRS. Now I have to figure out, if I can, whether this is a complete hard block, and we just got lucky. So the technician, when they were doing this ECG, maybe this was a complete hard block, but when they hit the button to record, what happened was they recorded only this session where things look 3-2-1. So what do you have to do here? You have to take a look at the PR interval. I mean, if you can, let the machine run and see if this alignment doesn't change. So if this alignment doesn't change for several seconds, when I say several seconds, I mean more like 30 seconds or a minute, then indeed you have a 3-to-1 conduction block. However, if you see your QRS moving towards your P wave, or your P wave moving towards your QRS, then you have something else going on. So right now, what I'm going to do is I want to take a look at the PR interval. So this is my PR interval on this beat. So I just copied, right, the box is identical. This is my PR interval on this beat. And that's the same. Here's the same box. I'm going to drop it down here. Now here things are, see here? It looks like the PR interval should be a little bit longer. See that? Should be over here. So this is just a hair, lickety split, not a big deal. Or maybe it is. But what I'm going to do here is I'm going to move this up here. Why? I'm just getting a nicer cutoff, the start of a QRS. See, the P wave starts over here. So this is a little bit longer of a PR interval. Okay. And this QRS is different. So there's something going on here. However, this is still close enough that I can say that yes, this P wave is agitating the ventricle into contraction, okay? And I can say the same thing over here. And I can say the same thing over here. Okay, so there is a correlation here. That correlation in this case happens to be, it happens to be 3-to-1. So what we have here is a 3-to-1 atrioventricular conduction, right? Three-to-one atrioventricular conduction. Now it seems like that's it, right? No, we're going to keep going. So I want to see here, the axis seems to be fine. As far as the R wave progression, that's a whole different story. What was I gonna say here? AVR is inverted as it should be. Everything else seems to be fine. The T wave has a P wave hidden in it. Up here, there's a beautiful example of that. See that? Okay. And now let's talk about, and I'm sorry, we have 3-to-1 conduction, which implies that here we're talking about a second degree AV block. Okay, so this is not a complete heart block. In a complete heart block, there would be no relationship between atrium and the ventricular, the atrial beats and the ventricular responses, right? You would be looking at two separate things. For a moment here, I was thinking that this could be a junctional escape rhythm, and it certainly had all the criteria for it, right? We were looking at a wider QRS. The rate was exceptionally low. And however, the PR is staying consistent. So for right now, unless I get different information that tells me, no, this indeed is junctional, for me, there's definitely a relationship between this P wave and this QRS, between this P wave and this QRS, between this P wave and this QRS. So there's a relationship between them. And that relationship is consistent. So we're not looking at a junctional escape rhythm. Actually, at this rate, you would more likely expect a idioventricular rhythm. Now, this patient could be on some sort of beta blockers or some sort of medication to keep the heart rate down, and it's keeping the heart rate down universally. And that's why we're seeing this relatively narrow rhythm instead of some sort of a idiopathic rhythm. Okay, so where is my? I feel like I'm a little bit slow. So I wanna talk about this this block. So during blocks, right? We have several different blocks. You have first degree, second degree, type 1, type 2. We have third degree, and then you have gray areas of all of that. But really, so in this case, we get one signal, that signal gets blocked. Then we get another signal, and that signal also gets blocked. And then finally, the third signal makes it through, and it starts depolarizing the ventricles in a consistent relationship of 3 Ps to 1 QRS response. So that's what's going on here. Now, what's often not discussed, so when we talk about blocks, for example, at PEGA, we have an extensive lesson group on blocks. It's not small. It's not something that we cover in 1 hour. We cover in several days, actually. Where was I going with this? Oops. Okay. So with blocks, oftentimes, oh yeah, that's where I was going with this. With blocks, oftentimes, or actually in the ECG world in general, there's so much focus on hieroglyphics, right? So somebody tells you, memorize this right here. This is what Mobitz-II looks like. This is what second AV block, and I really should say up here, type 2. Okay, type 2. This is also known as Mobitz-II. And what else was I going to say? So yeah, somebody will tell you, okay, memorize this. Every time you see this, call it that. You know, that's memorization of hieroglyphics. So you're looking for pattern recognition. That's okay, but that's you know, if you want to be a serious technician, if you want to understand what you're doing, forget about that. You know, use it sparingly, if you will. Now, the AV node, right? These blocks are called AV blocks, right? Atrio-Ventricular blocks. So something happens in that signal conduction between the atrium and the ventricle, and it gets blocked. Now, if we zoom in on the AV node, this is what it kind of looks like. So this is a representation of the AV node. Now, we're not going to talk about slow and fast pathways. We're not talking about SVT here and reentry tachycardias. So this stuff over here, feel free to ignore if you can. Maybe I should have put a box over it or something, but it doesn't matter. So your AV node gets kind of broken up into this transitional zone, and that's the first layer of cells, if you will, that receives the signal that's coming down from the SA node. And it comes down from the SA node, right, via various pathways, but I don't want to expand into that subject too much here. And in this transition zone is typically where you see your Mobitz-I. So this is typically where you see Mobitz-I or your, what do you call it, Wenckebach. So Mobitz-I, Wenckebach, same thing. It would be your second degree type 1. This is where you would see it. Okay, and this is not, again, this is a representation, so this is not clinically or physiologically, anatomically accurate. Okay, now we get into the compact zone here. You still can get Mobitz-I. You can also get Mobitz-II. However, when we get down here, see there's a bunch of, let me backspace a little bit. I just want to draw. So if you can imagine, you know, this is still your atrium. So this is still your atrium. The AV node lies, let me go back here. See, the AV node lies at the bottom of the right atrium, right? So it's still in the atrium, which is important. And where's my AV node now? Here it is. So the AV node lies in the atrium, and it can get bombarded by signals from the atrium. Okay, so it doesn't necessarily have to receive the signal up here. It can receive the signal down here. However, at some point, and this varies from person to person, but generally, once it starts bottlenecking off, here you're entering the bundle of His, okay? Here you're entering the bundle of His, and all of these fibers, all of these thick fibers, they narrow down into this tight, compact tubule. And here is where Mobitz-II occurs. So if there's some sort of a blockage or a degradation occurring in this bottleneck as it's exiting the atrium, you know, no signal can come down here and bypass the blockage, right? So your Mobitz is your Mobitz-II is oftentimes referred to as an infranodal block. Now, if this is the first time you're hearing that term, I'm going to repeat it, right? So here's your AV node, referred to as the node, and then anything below the AV node is referred to as infra, meaning below or less than. Infranodal. Okay, infra. N is for nodal. Okay. So your Mobitz-II is occurring over here, and it's an all or nothing type of a block. So either lets something through or it doesn't let it through. Versus Mobitz-I, not to go into Mobitz-I here, but I am going to mention it. Mobitz-I works utilizing a different property, or a different property of the AV node is being affected. But with Mobitz-II, it either happens or it doesn't happen. Okay, now let's go back to the ECG. Typically, when you see Mobitz-II, you're going to see a lot more QRSs, and then maybe an occasional P wave is going to be dropped. However, when you have a lot of Ps, a lot of atrial stimulus, and then an occasional QRS, what you have is you have a high-grade block. So this is still a second-degree AV block. It's a type 2 or a Mobitz-II, but it's a high grade. So it's a higher grade of the same block. Okay, here we're getting many signals, and we're only getting a single response. Versus typically what you would see is you would see maybe 3, 4 of these QRSs, and then one suddenly drops. The key thing with Mobitz-II or type 2 is that your QRS, your PR segment length remains the same. And this is what's telling you that this is an all or nothing block. Okay, this is an all or nothing block. It either happens or it doesn't happen. It's not, heating up, slowing down, this and that, so on and so forth. Now, I'm going to bring this back down. Sorry, I am jumping in. I'm making a little cutout here. I forgot to mention this. I mean, I had this up here, and I really wanted to use it. So I want to cover this. So, this is a graphical representation. This is computer generated, right? This is not real, but it is based on real ECG data. This is something that's known as a ladder diagram, and if you want to get real good at reading ECGs, this is something that you will have to get introduced to at some point. Not to get into it, I'm just going to use it to illustrate a point here. So when we're talking about typical Mobitz-II that you will see out here, this is what I was talking about. See how, over here, faded in the background, that would be your normal sinus or expected established rhythm going, right? During Mobitz-II, you would get a sudden stop. So the signal would start in the SA node, it would propagate to the atrium, but it wouldn't go beyond whatever's below the AV node. Let's say the AV node, that's where it stops. And you would get an occasional dropped beat. The high-grade version of that is it stops the beat maybe several consecutive, actually it has to stop at several consecutive times, at least twice, before it actually conducts again. So here we still have, just like in our example, we have 3 Ps to 1. The next one finally conducts, right? And again, so that's what a high-grade block would look like. Now, there are many, many different versions of this, right? You have 2 Ps, 5 Ps, 6 Ps, whatever the case is. Well, I got carried away there. 6 Ps. Now we're getting into some shady territory. We have to start talking about ventricular standstills and what is a complete heart block and so on and so forth. Even though down here it's kind of, this is one version of it, right? You get P's all over the place, and then there's an independent rhythm, a lower pacemaker that's firing at the same time. You know, there would be a complete heart block, complete AV block. But I really wanted to focus on the high-grade block and show you what that looks like on this ladder diagram. This is something that we use extensively in the classes. It really helps illustrate the point, and hopefully it helped you here. But I do want to talk about, sorry, I'm just going to delete a bunch of this stuff. I do want to talk about this right here, because this is unexplained, okay? And I don't like things unexplained on the ECG. And this gets us into a far more advanced session on an ECG. Okay, so what do we have here, right? You got your P wave, you got your P wave, you got your P wave, and finally we get a QRS, right? Let me put D for depolarization on here. And then you get your P wave, right? D for depolarization, so on and so forth. And it's no different over here, except look at lead 2, right? Lead 2, the mean vector of this is going towards lead 2, and then here it reverses. If we take a look at this QRS and measure it out, we have 1 box, 2 boxes, 3 boxes, 4 boxes. This is 160 millisecond wide QRS. So there is something going on here, and it's most likely a bundle branch block. Okay, now for bundle branch blocks, you go to V1, right? You go to V1, and if we measure it out over here, our first deflection from the baseline starts right there, and it ends as our, S wave comes back down to the baseline, R prime comes back down, and here 1, 2, 3, 4. So this is indeed 160 milliseconds wide QRS, okay? We have our bunny ears, and more importantly, we have secondary repolarization abnormality. So whatever's going on here with the QRS is causing an inversion in the T wave, okay? That's you know, if you just had bunny ears and no inversion over here, you'd have to really think about what it is that you have in front of you, okay? It may be a bundle branch block, but it may not. But if you have this secondary repolarization abnormality over here, then indeed you are looking at a bundle branch block. And I want to confirm that by looking at the lateral leads. Here I'm in lead one. Look at this. This S-wave is supposed to just pop down and come back, but no, here it slurs. And if you were to measure this QRS, right, here you get 1, 2, 3, a little bit over 3, maybe right at 3. So here it's at 120. So even here, even though this beat and this beat are not the same beats, right? They're not the same beats. But here it's telling us that there is an intraventricular conduction delay, and here it's telling us that that intraventricular conduction delay that looks like a right bundle branch block has occurred completely over here. So let me show you what's going on the in the conduction pathway. So this person, I'm just going to make these lines a little bit thicker. So this person has a Mobitz-II type block, and it's a high grade, so it's infranodal. So there's something going on with his bundle of His or her. I'm not sure. I don't know anything about the patient. And then occasionally in this beat, in particular over here, what happened is the signal was getting through. The signal was barely getting through, right? It was trying, and finally something gets through, and then trying again, and something gets through. But here on this beat, we're just talking about, this beat, right? Where we have this right bundle branch block that appears out of nowhere. It's not out of nowhere. Again, this looks like a partial right bundle branch block, and here it goes to a complete bundle branch block. So what's happening is this person's conduction system is so diseased that in the bundle of His, there's an issue. So the bundle of His over here, there's an issue. It's diseased, it's sick, right? There's, I don't know, something's going on with it. So much so that it's creating a Mobitz-II type block, but also the right bundle is partially affected. And so the signal, as it's traveling, it gets blocked. It gets blocked the second time. And the third time, when it gets through, right, it goes both ways, except on that one beat. On this beat right here, normally we have, see, 120 milliseconds. It has a slurry S in lead 1. If there was more beats in V1, I would show you the difference, but we don't have it. So I'm just using lead 1 here to represent bundle branch block, right bundle branch block, excuse me. So here in this beat, what happens is the signal gets blocked completely. So typically it was having a hard time getting through, but here in this beat, it got blocked completely. So that's what you have going on right here, and that's a part of the reason why we have this PR elongation. That's a very complex topic that I don't want to get into, because we've gotten into we've broadened the topics here a little bit too much, perhaps, but the PR elongation here happened because this signal before it has already depolarized this tissue, and here it was having a hard time getting through. I don't want to get into that now, but nonetheless, I just want you to understand what happened here. So we have a partial right bundle branch block through and through. Okay, so partial right bundle branch block, the slurry S is indicative of it, and then boom, we get a full right bundle branch block. Now conceptually, think about this. This person has a Mobitz type 2 high grade, so it's a higher grade. This is a hair away from being a complete heart block. And then also the right bundle is failing. Pretty dangerous. Okay, I think, oh yeah, I do want to mention this. So anytime you get these blocks, they could be transient, or they could be permanent. You know, they could be, no, I forget the term now. Essentially, it means temporary or permanent. But anytime you get blocks, you have to start thinking, why are they happening? Is this patient on too much medication? If not, then what else is happening? Maybe something happened to them, some test that they were doing at the hospital, and the consequence of that is a transient second-degree block. You can have transient, complete heart blocks. However, you should always be thinking about supply lines. Okay, so the AV node has to get its blood from somewhere. And when you start looking at these diagrams out in the literature, you'll see a lot of times, 85, 15, so, or 90, 10, or RCA was the dominant artery. What I'm trying to tell you is that one diagram will not be representative universally of everybody out there. Some people will have multiple arteries supplying the AV node, the SA node, so on and so forth. However, you should be thinking about blood supply to the AV node, because this AV node, or where was I? Excuse me, here I'm talking about the AV node, but really I should be talking about the bundle of His. You got to be thinking about what supplies that region. And anytime I get blocks, I'm always concerned about ST elevation and other things that might show up with a lack of perfusion to the heart. So now that I've opened up several different topics, and maybe you're a little more confused than you were when you started this video, I want to bring back this nice little white screen that it tells you what it is. So here we were looking at a second degree type 2 Mobitz-II AV block, so atrioventricular block, but this is a high-grade version of it. Okay, high-grade version of it. So 2 P waves or more per every QRS equals a high-grade block. And you can have variations. Maybe you would have 3 Ps here to a QRS. Maybe there would be 2 over here, or maybe there would be 5 over here to a QRS. But the PR preceding that QRS has to be consistent. It has to be the same. All right. Thank you, everyone. And I hope it wasn't too much. I hope you didn't fall asleep. But we'll see you on the next one. Thank you.